your clinic on a day-to-day basis. We will obviously travel a little bit into the sporting realm for when we look at ankle sprains, because that's typically how they happen, but they also happen off-court, off-field as well. And we'll finish up the day with some mobilising and exercise programs and recruitment of various dysfunctional muscles to finish off. So that's the plan, and we're a nice tight small group, so it's going to be easy to ask questions. It's going to be easy to delve into various things that are of interest to you. However, if we dig too deep on some things, we're going to be shallow on others. So I'll try and get a feel from the group if we want to pursue that topic in a bit more. I've got an idea of what I want to get through, but you may have some other things you're hoping for, so don't hesitate to bring them up as we go. Ankle joint, here we go. It's not a simple hinge joint. How often have you read that in anatomy books? Nothing's a simple anything when you get to anatomy. It's a hinge joint, but not a simple hinge joint. The bimalleolar axis obviously isn't straight transverse, it's anterior, medial, posterior, lateral. So automatically when you plantar flex, you adduct the foot. Automatically when you dorsiflex, you abduct the foot, and there's nothing you can do about that if your syndesmosis is intact. However, there are some interesting things that happen clinically around this front line joint of the talocrural joint. In the talus itself is much broader at its anterior margin and quite narrow at its posterior articular margin, so the close packed position is full dorsiflexion. When you jam it in, it's jammed in, and there's no talar tilt within that mortise joint at all. Also, when you fully dorsiflex, the articular surface is fully enclosed within the housing of the tibiofibular component. When you plantar flex, there is articular surface palpable. For the difficult ankles, if you have had a traumatic injury and a sprain or impact injury, and they are not performing as you would expect them to recover, it's useful to be able to palpate this articular surface of the talar dome. You can only do it, obviously, in plantar flexion, however. So if you palpate the anterior joint line of the ankle joint in full dorsiflexion, you are palpating tendons, retinaculum, capsule, and the ligaments, particularly the anterior talofibular ligament on the lateral side, but you're not palpating the articular surface. If you then palpate in full plantar flexion, the only thing you've added to the equation is access to the talar dome. If you now palpate and you have a lot more tenderness, it is that structure that's reporting that tenderness. So if you have a suspicion that the ankle that's not improving very well has some osteochondral fracture or a talar dome microfracture beneath the chondral surface, and they're tender, and they're not meeting the clinical markers of recovery, that palpation as part of the confirming your index of suspicion is a very useful component. So they won't have the tenderness on dorsiflexion, but they will have the tenderness on plantar flexion, and the only thing that's changed is we've got access to that talar dome.